Okay, we're going to start with Dr. Julie Bykowski presenting her unique "What the heck is this?" case on accessory salivary tissue with a boutonniere deformity from the University of San Diego Health. Looking forward to this interesting case.
Hi, this is Julie Bykowski. I'm faculty at UC San Diego Health, and this is my Earlybird case. We had a 51-year-old gentleman who came in for his surveillance MRI 1 year after a right buccal space myoepithelial carcinoma resection and adjuvant cisplatin radiation therapy. This is his axial and his coronal fat-saturated T1 weighted images with the arrows indicating the 2.2 centimeter left or contralateral submandibular space mass that we saw extending through the mylohyoid. And obviously a contralateral process in somebody who had a right buccal space tumor is of primary concern, and we went back to his original staging to say, did we miss something? So on his initial staging CT, the leftmost images, we didn't see his buccal tumor because of dental artifact, but his right periparotid lymph nodes indicated by arrows were present. And in retrospectively, you can see the left submandibular lesion, subsequently seen on the MRI, is tucked up against the mylohyoid, but was iso-intense both to the muscle and the adjacent submandibular gland. FNA attempt of this lesion at the time of the MRI was non-diagnostic, but it also did not reveal any malignant cells, but he subsequently went for excision, and thankfully this confirmed it was benign submandibular gland with the stigmata of being partially radiated as part of his therapy. I included this reference because it gives a nice example of the boutonniere or buttonhole defects. These areas of mylohyoid discontinuity are more common than we usually realize, but allow herniation of fat, vessels, sublingual or submandibular gland or ranula, and they may be bilateral or unilateral. In this case, good news for the patient. This was a benign process, but again, with retrospect, looking for all your fat planes can help you identify prospectively when there's an anatomic variant in the setting of our cancer patients. Thanks.
Thank you so much, Dr. Bykowski. We're running a little tight on time, please, so we're going to start now with Dr. Dahlstrom presenting a unique case on what the heck is this, and we'll be looking at her adenoid cystic with contralateral perineural spread.
From the University of Utah, and I will be presenting the next case for What the Heck is This? I'm presenting a 38-year-old female with left cheek mass. Here we have axial MRI sequences. We have axial T1 pre, post, and T2 weighted images. We have a T1 hypointense enhancing mass with T2 hyperintensity involving the superficial and deep portions of the left parotid gland. A coronal T1 post sequence demonstrating infiltrative enhancement of this lesion. Now, this is not the diagnostic dilemma. A biopsy was done consistent with adenoid cystic carcinoma. The patient underwent surgery and postoperative radiation were followed uneventfully until January 2012 when they developed double vision. An MRI was done at this time. We have a coronal T1 post sequence demonstrating abnormal enhancement and thickening extending through the left foraminal valley with additional abnormal enhancement along the left semilunar ganglion within Meckel's cave, as well as asymmetric thickening and enhancement within the left sella, an adjacent cavernous sinus. A follow-up MRI done 7 months later, demonstrating increased enhancement, again through left foraminal valley, involving the left cavernous sinus, as well as the sella. Follow-up MRI, again demonstrating progressive increased enhancement. And now we see abnormal enhancement within the right cavernous sinus. Follow-up image 3 months later, demonstrating again progressive increased enhancement within the previously demonstrated areas. Now with impressive enhancement of the bilateral cavernous sinuses, we now see enhancement extending through the right foraminal valley. And again, further increased enhancement with marked abnormal enhancement of the bilateral cavernous sinuses along the sella and through the bilateral foraminal valley. So this is an impressive case of perineural tumor spread. We know the connection between the facial nerve and V3 segment via the auriculotemporal nerve, which we see here. So tumor spread along the auriculotemporal nerve along V3 through foraminal valley to the trigeminal ganglion within Meckel's cave. Then anteriorly along V1 and V2 to the left cavernous sinus. Travel to the contralateral cavernous sinus via the intercavernous connections, which are inferior to the pituitary. From the right cavernous sinus, transmitted posteriorly to Meckel's cave, and then inferiorly along V3 through the right foraminal valley. So again, this is an impressive case of perineural tumor spread from the left parotid adenoid cystic carcinoma. Thank you.
So thank you so much, Dr. Dahlstrom, for that interesting case. We may run a little tight for time on questions, so please text those for her. Be curious if it also spread along toward the genicular ganglion, toward the mastoid. We've seen that as well, the Avidian branches and GSPN. Our next speaker will be Dr. Zander, who is from Colorado, my old home state, who is going to be presenting us a unique case of trigeminal neuralgia with MC malformation. So we'll keep us right on time, starting his in about 10 seconds.
Good morning, Earlybirds. This is David Zander from the University of Colorado, and I've got a question. What the heck is this? Presenting the case of a young woman with right greater than left facial pain. It's been debilitating for many years. She once held the diagnosis of intracranial hypertension, but opening pressures have now normalized despite no directed therapy. Unfortunately, gamma knife to the right trigeminal nerve was unsuccessful with no relief of pain. Now the patient resorts to biweekly sphenopalatine ganglion blocks with only partial relief of symptoms. Let's look at her cranial nerves on this axial KISS sequence. So we make our way past the optic chiasm, the third cranial nerves. Things look relatively normal. However, when we get to the cisternal segment of the trigeminal nerves, one thing is suspiciously absent, and that's Meckel's cave. It should be right here, comprising the dural cave segment of the left trigeminal nerve. Here on the right, there is a little bit of a cystic structure, but we see it a little bit better on subsequent images or subsequent slices. Here, it's a cystic structure apparently centered within the right petrous apex, contains some nodularity, maybe some stellate material. Medially, it appears to communicate with Dorello's canal. For comparison, here's Dorello's canal on the left housing the sixth cranial nerve. The remainder of the six cranial nerves, seventh and eighth cranial nerve complexes, and lower cranial nerves are otherwise normal, noting a little bit of CSF distension surrounding the lower cranial nerves. In the coronal plane, there's concavity of the cavernous sinus bilaterally. That continues throughout the length of the cavernous sinus. As we get to our cystic lesion of the right petrous apex, you'll see that it's separate from the mesial temporal lobe. As such, this is unlikely to be an encephalocele. In fact, the two structures are actually separated by what appears to be a small membrane. More posteriorly, the cisternal segments of the trigeminal nerves are normal, and again we see the remainder of the lower cranial nerves. On a post-contrast sequence, much like on the coronal KISS, the cavernous sinus is concave in margin bilaterally. There's minimal to no enhancement associated with the cavernous sinus, seen best here at the level of the sella, but it continues the length of the cavernous sinus. At the right petrous apex, there's no enhancement to correspond to the nodularity we had seen on the KISS sequence.
Okay, I'm gonna leave this thing. I don't wanna. Okay,
For comparison, here's a normal cavernous sinus on the right. It's full of venous enhancement. There's filling defects associated with the internal carotid arteries, cavernous segments, as well as the cranial nerves, cranial nerve 3, V1, V2, and cranial nerve 6. While there may be some nerves seen here lateral to the sphenoid sinus on our patient, there's really nothing to speak of here on the right. MRV shows moderate to severe tapering of the transverse sigmoid junctions, a finding that's associated with intracranial hypertension. So, what the heck is this? Petroclival cystic structure? I don't know. Is it a meningocele? Is it a dysplastic Meckel's cave? What about the remainder of the markedly abnormal central skull base? Where is Meckel's cave on the left? Is the cavernous sinus hypoplastic, aplastic? Is it some form of congenital abnormality? Is this somehow a manifestation or perhaps even a cause of intracranial hypertension? Your thoughts are appreciated. Thank you.
So, Dr. Zander, thank you very much for that interesting case. What was unique is I wonder if there's some association with the variability of the sinus and how it forms. So there's a very pneumatized sphenoid with extension into the infralateral plate. So if you have any thoughts on that, that was a very unique anatomy. In case we have a few seconds to answer some questions on that.
Sure, definitely. I was just surprised at how abnormal the remainder of the central skull base looked. As you said, fairly pneumatized sphenoid sinuses. The cavernous sinus was just really not there at all. So I don't have a great way to explain it. And I wonder what we could do for this patient with her trigeminal pain. I don't know if there's much we could offer.
Yeah, it's great. There's an excellent article by Dr. Fishbein that was written several years ago on features apex cephalocele. So really unique case and a very interesting anatomy. One of my favorite nerves, the trigeminal nerve. So thank you so much for presenting that. Our next speaker is going to be Dr. Alvin Hassan-Khani, who used to be my colleague here at Northwell, but then he went on to bigger and better things over at the University of Pennsylvania with Dr. Lori Lubner. And he's going to present for us a unique case of multifocal cystadenoma with focal oncocytosis. Looking forward to this unique what the heck is this case.
Hi, this is Alvin Hassan-Khani from University of Pennsylvania. I want to thank committee members for allowing me to present this case of a 75-year-old man who sought medical advice for a slow-growing mass in the left cheek on physical examination. A non-tender mobile firm lesion was palpated at the angle of the jaw. Past medical history is significant for resection of cutaneous squamous cell malignancy several years ago. On CT, we are seeing this dense lesion in the superficial portion of the left parotid gland at the level of the left parotid tail. We also found 1 or 2 additional lesions on the contralateral side, similarly situated. MRI was helpful in further characterizing the lesion. It appears that the lesions to be fairly well circumscribed, well defined. The fat surrounding was clear, and they were hypointense on T1 and homogeneously bright on a T2 stare, and following contrast, lesions were not perceptible. Based on the clinical presentation and imaging, we provided a differential diagnosis of could this be intraparotid lymph node, cystic nodes, especially metastatic disease was a consideration given history of skin malignancy, as well as cystadenoma lymphomatosum, given the location of the lesion and the age of the patient. Prior to fine needle aspiration, sonography showed these lesions to be purely cystic, and the aspirate showed few atypical squamous cells. Final diagnosis was made following superficial parotidectomy, and lesions revealed to be multifocal oncocytic cystadenoma. So what the heck is multifocal oncocytic cystadenomas? These are rare, benign, slow-growing lesions, slightly more common in women. They result from oncocytic transformation of epithelial cells lining the salivary ducts and acini. They have been described in pancreas, but in head and neck, there have been some case reports of these lesions appearing in the larynx and arising from the minor salivary glands at the level of the buccal mucosa and palates. On histology, these are cystic lesions filled with serous or mucinous material lined by oncocytic cells. This is in distinction to oncocytomas, that they tend to be more solid lesions with layers and layers of solid oncocytic type cells. Oncocytes are cells with characteristic histological cytoplasm of numerous mitochondria and granular features. These lesions resemble cystadenoma lymphomatosum, but distinctly they contain no lymphoid elements. There is no large follow-up series of these lesions, but they felt to be benign. Although a definitive diagnosis requires histopathology, I think awareness of these lesions is going to be important when it comes to differential diagnosis of cyst or cyst-like lesions involving the major salivary glands in appropriate age groups. Thank you very much, and I look forward to discussion.
Thank you very much for that interesting, very, very interesting case. So is there any unique characteristics, like sometimes there's a delayed enhancement or anything? Did you do any other imaging modalities to take a look at the analysis of that type of tumor, Dr. Hassan-Khani?
Yeah, hi, good morning. Yeah, we didn't expect this type of diagnosis. As mentioned, we were favoring this to be metastatic lymph nodes based on the history of primary skin malignancy. So we didn't, pursue these lesions before the surgical intervention.
Interesting. And any association with smoking, or just no? Because we know Worthman's definitely has a smoking association.
Yeah, it's such a rare entity. It's considered to be benign based on few cytological reports on this entity. I didn't find anything associated with smoking. I believe our patient was not a smoker either.
Wow, thank you so much. That was a really, really interesting case. I love these cases because they kind of make you think about things in a new way that you kind of expect, and then you find something and it kind of surprises you. So it's always great cases to learn from. So thank you so much for presenting. Our last one that I will be introducing, then I will hand it over to my co-moderators, Dr. Cornelius and Dr. Mukherjee, is I'm very honored to introduce Dr. Nancy Fishbein. She's a professor at Stanford, who's going to be presenting a unique case of amyloid, another very interesting and fascinating diagnosis.
Hi, I'm Nancy Fishbein from Stanford Neuroradiology, and I'd like to share a case with you today. My patient is a 55-year-old woman with 10 months of right facial palsy that was unresponsive to steroids or antivirals. She also complained of numbness of the right face but had no pain. On exam, she had decreased sensation of the right face in V1, V2, and V3 distributions, as well as mild right facial weakness. On T2 weighted imaging, we can see that she has this intermediate signal intensity tissue involving the trigeminal ganglion and extending inferiorly along V3 through a widened foramen ovale, as compared with normal Meckel cave and V3 on the contralateral side. On T1 weighted imaging, the soft tissue is intermediate in signal intensity as well. And post-gadolinium, it enhances intensely and homogeneously. ASL perfusion did not show any high signal to suggest high flow or hypervascularity, and diffusion-weighted imaging was also unremarkable, though there is quite a lot of distortion at the level of the skull base. Thinner section imaging showed extension of gadolinium enhancement along the greater superficial petrosal nerve to the level of the geniculate ganglion, and also involvement of the labyrinthine segment of the right facial nerve. Coronal high-resolution T2 weighted imaging showed thickening of the individual divisions of the trigeminal nerve as compared with the contralateral normal left side. Our differential was broad and included neoplasms such as lymphoma, metastatic disease, or histiocytic disorders, infiltrative non-neoplastic processes such as sarcoidosis, IgG4-related disease, or inflammatory pseudotumor, though our patient had no pain. We also considered infections, particularly granulomatous infections such as syphilis, and what we did not like were typical Meckel's cave lesions such as schwannoma or meningioma, or any kind of vascular lesion. Our patient underwent further evaluation with a chest CT that was negative. FDG PET-CT was not approved by her insurance, but a biopsy was subsequently performed via an orbital zygomatic approach. Intraoperatively, the surgeon found that both V2 and V3 appeared to be infiltrated by abnormal tissue, as was the trigeminal ganglion, and there was no obvious plane of dissection between the cranial nerves and this abnormal infiltrate. Pathologically, this proved to be amyloidoma. Primary amyloid tumors of the CNS are rare. They are described in the cerebral parenchyma, the spinal cord, the pituitary gland, and the trigeminal ganglion, but nonetheless, they are rare. Secondary amyloidosis is much more common, associated with conditions such as plasmacytoma, chronic renal failure, rheumatoid arthritis, and familial transthyretin mutation. Our patient was seen in follow-up in amyloid clinic. Her final diagnosis is localized amyloidoma of the trigeminal nerve and facial nerve of the lambda light chain type. She had a normal bone marrow biopsy, no monoclonal protein in blood or urine, and no evidence of any other organ involvement. The current plan is for clinical and imaging follow-up. These are my references, and I thank you for your attention.
So, Nancy, thank you so much for that interesting case. I've always found the deposition of amyloid and the process of inflammatory change quite fascinating. We don't quite know all those mechanisms, but I've always wondered, is there an underlying genetic, mutation, or is there any sort of history anywhere in the family? I don't know if you saw any of that in your research.
Well, I think with this patient in particular, no, we didn't specifically, Claudia, but, obviously women have a lot more autoimmune disease in general, just in the population. And I think that her problem may have related to an autoimmune disorder that's still being worked out. But mostly it was just an interesting mystery. And in retrospect, I think something that could have really helped me was if I had focused more on really the infiltrative expansile thickening of the 3 divisions, and maybe amyloid would have popped to mind. So thank you.
No, I agree. I find it's Chestnut. I don't think any of us would have jumped to amyloid on our first choice looking at that case. It's really fascinating. But it is these infiltrative inflammatory processes that occur can track exactly, like you said, along these nerve pathways and involve these cranial nerves. So really unique and beautiful case. Thank you so much for presenting. And I will now hand it over to my next moderator, Dr. Mukherjee, who will be doing the next series of our What the Heck is This Unique Cases.
Hey, good morning from the East Coast. Just a sound check. Can everybody hear me out there in cyberspace, I hope? Okay. I saw David nod his head, so I assume that's a good thing. So welcome. This is going to be session number 2. And first, and I won't say what the answer is, so you guys will have to figure it out on your own as we sort of evolve through the presentation. Will be presented by Dr. Uhud Al-Aslani, sorry about that. Uhud Al-Aslani from Ottawa.
Hello everyone, this is Uhud Al-Aslani. I'm a neuroradiology fellow in the Ottawa Hospital, Ontario, Canada. Me and my colleagues would like to share this case with you for the session. So this is a 54-year-old lady who presented with voice changes over 1 year. So here we have selected axial and sagittal non-enhanced CT scan images that show hypodense fat-containing lesion along the lingual surface of the epiglottis, protruding into the hypopharynx posteriorly, and we can appreciate some thin, faint internal septations. Pre- and post-contrast images in coronal plane show no definite enhancement. Further down, we can see that the lesion is filling the vallecula bilaterally. So this was the case of supraglottic liposarcoma. We know that liposarcomas are one of the most common soft tissue sarcomas in adults, but we rarely see them in the larynx and hypopharynx. Only a few case reports are present in the literature. Histologically, they're divided into 4 subtypes: well-differentiated atypical, lipomatous tumor, myxoid round cell, pleomorphic, and dedifferentiated. They usually affect male patients in their 5th decade of life, and some of the proposed etiologies include previous trauma, genetic predisposition, and radiation. Clinically, they can present with progressive breathing and swallowing difficulties over several weeks up to years. Clinically, they can be seen using laryngoscopy as polypoid pedunculated masses. Imaging features can resemble that of benign lipomas, but few features can help us make the distinction. For example, larger size, presence of enhancing thick septations or soft tissue components, and relatively low proportion of fatty components. On MR, their signal intensity of the fat content should resemble that of subcutaneous fat. And we can see septations or non-lipomatous elements which may show post-contrast enhancement. Differential diagnosis would include benign lipoma. These are well circumscribed and their fat content usually is homogeneous on imaging. Fibrovascular polyps are lesions in the upper esophagus. They're usually solid, but sometimes they can contain fat as well. Epiglottic cysts are non-enhancing cystic lesions arising from the epiglottis that can sometimes have similar imaging features. This lesion is treated by wide surgical excision. So that concludes my presentation. Thank you for listening and enjoy the rest of the lectures. Thank you.
Great. Thank you very much. Well, first of all, great presentation. Second of all, I want to thank you for not saying elderly male in the 5th decade, because when I was a fellow like yourself, I used to call everyone in the 5th decade elderly. So I do appreciate that. One thing that I wanted to ask, and you and maybe on the chat box as well too, is sometimes we do see, not necessarily in the visceral space, but we also see lipomas involving the soft tissues, the subcutaneous tissues of the neck. And we sort of know it's a lipoma, but we sort of see a little bit of stranding. So for instance, like if this case was an earlier case, let's just say if we saw it earlier and it was smaller, I think the challenge comes in is what do we do about follow-ups? Because in general, we think that it's going to be a fatty, just a lipoma, but in this case, it turned out to be a liposarcoma. So I'm kind of curious if you have any thoughts, or maybe others in the chat box as well too, as to what recommendations can you give us regarding following these things that we think is a lipoma, but we're always worried about it could be a low-grade liposarcoma. So do you have any words of wisdom for us?
Actually, not really, because many of the cases, they think that liposarcomas, initially, they think of them as lipomas, and the only gold standard is pathology. But as I mentioned, some of the features that might be concerning makes us think more towards, makes something suspicious, and we can follow that up. But as a regular follow-up for just an incidental lipoma, honestly, I don't think at any of the centers I worked at, they would follow up a simple small lipoma.
All right, great. Thank you very much. Excellent presentation. The next presentation will be from another one of our Canadian colleagues from Ontario, Dr. Fatim Salehi.
My name is Fatima Salehi, and I'm a neuroradiologist at McMaster University in Hamilton. This is a case of a 54-year-old male who had resected GIST in 2014 through Whipple's procedure and was undergoing routine surveillance imaging of his chest, abdomen, and pelvis. His routine surveillance then demonstrated this enhancing nodule at the right retropharyngeal area as pointed by the arrow. The differential considerations that were raised included a parathyroid adenoma or accessory ectopic thyroid tissue. An ultrasound was recommended, however, there were no findings on the ultrasound. Move forward 4 years later in 2018 when the patient presented with swallowing difficulty. Another CT neck was performed and demonstrated this enlarged, quiet while enhancing lesion in the right retropharyngeal area, as seen on the coronal image here and on the sagittal image here as well. A similar differential diagnosis was provided, and a nuclear medicine study was suggested, thinking about parathyroid and thyroid tissue. The nuclear medicine study, however, was negative, and then the patient had a percutaneous transjugular fine needle aspiration of the right retropharyngeal mass. Before I reveal the pathology, I will note that the patient was examined and was found to have multiple cutaneous nodules. He also was found to have remote resection of skin nodules and a family history of skin nodules and colonic polyps in his brother. After thorough clinical investigations, it was made known that the patient actually had NF1. He did refuse genetic testing. So before I go to the diagnosis, I'll pause for a second. We have a patient who has NF1 and has this very enhancing mass in his neck and a history of GIST. The biopsy reveals sclerosing rhabdomyosarcoma, which is a very rare tumor in adults. It's the most common childhood soft tissue sarcoma and occasionally occurs in context of a predisposition syndrome. The most common predisposition syndromes include germline TP53 mutations and constitutive alterations in RAS pathway activation. These include NF1, Li-Fraumeni, and Beckwith-Wiedermann syndromes. This could also occur as radiation-induced second primary neoplasm. Adult rhabdomyosarcomas are very rare. However, they're 20 times more prevalent in patients with NF1 than the general population. The bladder and prostate are the most common sites of involvement, and in children, then these are followed by the head and neck, trunk, and extremities. The 5-year overall survival for a localized rhabdomyosarcoma is greater than 70% in children who are under 18 and is very poor in adult patients. One of the largest studies conducted in France with N of 449 people demonstrated that 5-year overall survival for patients with localized and advanced disease was 43% and 5% respectively. And this patient who only had localized disease received chemotherapy after treatment with resection and has been disease-free since 2018 and is being followed up with serial CTs. So in this case, I would encourage to consider the diagnosis in patients that have NF1. I'll take any questions if there are.
Thank you very much. Based on the comments to the chat box, I think you had a real great case. A lot of people haven't seen that entity specifically in that location. Just one quick question. Did this patient have any other systemic findings at all of MF? I know when you were going through the presentation, you identified it as a localized lesion and then later said there was NF. Did they have other systemic findings of neurofibromatosis type 1?
So just looking at the clinical notes, it looks like the skin cutaneous manifestations were the ones that kind of cinched the diagnosis. There was no mention of other NF1 manifestations. We insisted, or the clinician insisted on referring the patient to genetic counseling, but there was no interest, unfortunately. So we're just going by the cutaneous findings.
Great. And then do you have any thoughts about which striated muscle that actually arose from?
I would defer to your expertise here.
Well, the visceral space tends to be there is some smooth muscle, but there's also the longest coli muscle, which is striated. I have to go back and look at the anatomy to see whether or not the esophagus actually has striated muscles. If I recall, there is smooth muscle. So I'm just trying to figure out the pathogenesis of that. But I'll have to do my homework and I'll get back to you with that one. So thank you very much.
Thank you.
Excellent. The next case will be from Dr. Jacqueline June from Mount Sinai.
A female teenager presented with a 6-month history of headache. The patient also reported tinnitus in the right ear. She first had an MR scan where we see an enhancing extraaxial mass along the petrous ridge, but when you look carefully at the extent of the enhancement, it also involved the aortic capsule and the posterior limb of the semicircular canal. This lesion did not have diffusion abnormality and was iso-intense on T2. Our initial thought was a meningioma. However, the extent of the osseous involvement puzzled us, as well as the lack of dural tail. In order to assess this further, we recommended a CT scan. CT imaging demonstrated erosion of the aortic capsule. It also involved the posterior limb of the semicircular canal and the round window. We were now able to expand our differential diagnoses, which included a meningioma. However, there was no dural tail. Also, we have osseous erosion instead of hyperostosis. Then we thought of an endolymphatic sac tumor, but the osseous changes were not typical moth-eaten appearance. Also, the lesion was not centered in the retrolabyrinthine region. Next, we thought of this could be Langerhans histiocytosis, but it did not have other bone involvement or extensive lytic osseous destruction and soft tissue mass as you would expect for this entity. Our next consideration was a paraganglioma. Again, the location of this mass argued against this lesion as it was not centered in the jugular bulb or the middle ear. Due to her symptoms, she underwent operation for resection. We were surprised by the final diagnosis, which was angiomatoid fibrous histiocytoma. This is a rare soft tissue tumor with intermediate malignant potential. Thus far, only about 5 intracranial cases have been reported, and our case is the first one presenting in this location to our knowledge. Other angiomatoid fibrous histiocytomas have been described to have intralesional blood in cystic spaces with fibrous pseudocapsule. Histologically, sheets of histiocytic cells mixed with organizing hemorrhage have been described. Here we have literature examples of other intracranial angiomatoid fibrous histiocytoma cases with cystic changes at the top and another case with pseudocapsule at the bottom. As demonstrated in our case, the differential diagnosis for a mass with this appearance in this region is broad, and there is significant potential for misdiagnosis. In a patient with concerning symptoms and imaging features atypical for more benign entities, surgical resection and pathology should be considered for more definitive diagnosis. Thank you.
Thank you very much. I can tell you, I certainly went to put that in my initial differential diagnosis. Is there any overlap between, I know there are a lot of blood products that you mentioned, is there any overlap between that and secondary aneurysmal bone cysts or other blood forming products, since these do tend to be hypervascular?
I think that was one of the considerations, but this is such a rare entity and it's arising from soft tissue as opposed to bone. So I think histologically they're different, and based on the more of the pathology literature we have, they're trying to still figure out what's the genetic abnormality with it. So in terms of genetic abnormality, the most common mutations were ESWR and CREB1 mutation for a lot of these tumors, but since this hasn't really been described in intracranial lesions, I think it's just kind of hard to tell like where we lie in terms of where this actually fits in terms of the spectrum of diseases.
Sure, that's a great answer. The other question I had too, this was a really rare diagnosis, and one thing I've noticed, unfortunately, I trained in the last century. I hate to say that. Actually, I trained in the last millennium. And, one of the things that I've noticed over time is that certain diseases give different names over time. And I've also noticed that the prevalence of diseases in some institutions, it's also predicated on the training of the pathologist at that institution. So the rarity of this disease entity, is this disease entity fairly well acknowledged overall as a specific disease entity, or is there a certain prevalence of this disease in certain areas or certain institutions, I should say?
I actually haven't. This was the only one that we saw. I saw this case when I was doing fellowship at UCSF. And from what I've seen in terms of literature, it's kind of all over the place. So I don't think it's institution biased, but I think that's to be remain to be seen in terms of how this plays out in terms of geographic or institutional bias.
All right, thank you very much. It's a fantastic case, and I'll have to include that in my next differential for skull-based lesions. So I appreciate that. The next case is going to be from Brazil. Dr. Hugo Tames will be presenting this case.
Hello, I'm Hugo Tames, a head and neck radiologist from Brazil, and this is a case from the University of São Paulo. The patient is 42 years old, female, HIV positive, diagnosed 10 years ago, and abandoned treatment for 2 years. She returns to the hospital with cervical bulging, dysphagia, and dysphonia. Initial ENT evaluation showed ulcerated and bleeding lesions in the oropharynx, and a neck CT was requested. These are contrast-enhanced CT images of the neck, showing a lesion on the nasopharynx, larger to the right, with circumferential involvement of the oropharynx, and we also see some abnormally enhancing level 2 lymph nodes. Inferiorly, this lesion extends to the hypopharynx, displacing anteriorly the supraglottic larynx, and we also see these lymph nodes with abnormal enhancement and some necrotic areas, some of them involving the sternocleidomastoid muscle and the paravertebral space. Sagittal and coronal images show the extension of the lesion from the nasopharynx to the hypopharynx, and in this coronal image, we can appreciate the nodularity and exophatic aspect of this lesion. These are the lymph nodes on the posterior cervical spaces, some of them involving the sternocleidomastoid muscle. So this was an extensive vascularized lesion with atypical lymph nodes in an HIV-positive patient. We reviewed her chart and saw that she had low CD4 cell count, high viral load, and violaceous lesions in lower extremities. A chest CT showed multiple flame-shaped lesions with peribronchovascular distribution, and a large lesion in the right inferior lobe. So the answer to this question is Kaposi's sarcoma. The patient was treated with antiretroviral therapy, and comparison of the initial CT with 6 months after treatment shows remarkable improvement of these lesions and also of the lymph nodes. Kaposi's sarcoma is an AIDS-defining illness and a borderline vascular tumor. Its most common head and neck manifestations are in the skin, the pharyngeal and oral cavity, and in the lymph nodes. It's important to remember this diagnosis in AIDS or transplant patients, particularly when they show multifocal enhancing disease. Differential diagnoses are squamous cell carcinoma and lymphoma. This is an article from Radiographics that nicely depicts the imaging manifestations of Kaposi's sarcoma. I'll leave you with a picture of São Paulo and from our head and neck radiology team. Thank you for your attention, and thank you to the ASHNR for this opportunity.
Great, thank you very much. Fantastic case. And just on a couple of personal notes, I know the group that you come from in São Paulo, they've been very supportive of the ASHNR for many years. So we appreciate the international support, and I know the quality and the mentorship that you're receiving down there. So thank you very much for your elegant presentation. I appreciated this too. I was glad I got this assigned this because, like I said, when I trained, when I was a resident, I hate to say this from in the 88 to 92, that sort of was in the AIDS era. And I still remember it was sort of drilled into us, the 3 head and neck manifestations of HIV. And it was a paper written by Roy Halladay years ago. It was lymphoepithelial cysts, adenoidal hypertrophy, and what we sort of call shoddy lymph nodes. And we specifically wanted to show this to this generation of trainees because you just don't see those manifestations as much anymore, but you know it's out there. And I know when I give my visiting professor talks and I show lymphoepithelial cysts 30 years ago, as soon as the case went up, people would end up getting it. But now the lymphoepithelial cysts are not necessarily at the top of the diagnosis for HIV manifestations. So I wanted to thank you for that superb case. And again, kudos to you and all the support that your organization and your institution and your mentors have given us for many years. Thank you, sir. The next presentation will be from University of Utah. It will be given by Daniel Meltzer.
Hello, my name is Dan Meltzer, and this is my Earlybird case. So here we have images from a 35-year-old female who presented with an oropharyngeal mass, and there was no other significant past medical history. The images are at the level of C2-3. On the T2, T1, and post-contrast FATSAT T1 images, you can see there's a mass pushing the oropharyngeal mucosa anteromedially. The mass is fairly homogeneous on T2 and T1, as you see. Some other pertinent findings: the internal carotid artery is deviated laterally, shown by the yellow arrow, and the internal jugular vein is also deviated laterally, shown by the red arrow. So right off the bat, we're thinking this is unlikely to be something of vagus nerve origin because that would typically splay those vessels. The external carotid artery is pushed anteriorly, shown by the pink arrow a little bit away from the ICA, but even though that might make you think of a carotid body paraganglioma, again, this mass is very homogeneous. There's no flow voids on T1 or T2. And the asterisk is showing you that the enhancement is very mild and patchy. The orange arrow is showing you that the parapharyngeal fat is deviated anteriorly, and that's something we classically see with a carotid space mass. And finally, the posterior belly of the digastric is pushed anterolaterally, and that's something that can help us distinguish that we're actually dealing with a carotid space mass rather than a mass in the deep lobe of the parotid. So, what the heck was that? The differential includes glomus phagali, but as we said, the pattern of vessel displacement is not good for that. There's no flow voids and only patchy mild enhancement. Similarly, for a carotid body paraganglioma, again, the pattern of vessel displacement, no flow voids, patchy enhancement, all go against that, and also the mass is a little too high in the neck. Vagal schwannoma, is a very good thing to consider, but again, the pattern of vessel displacement is not typical for that. You could consider nodal squamous cell carcinoma involving the retropharyngeal space, but again, the patient's age, she's young, and there's no past medical history. And finally, you could consider a neurofibroma in the carotid space. I didn't have a CT to show you, but there was certainly no target sign visible on that large mass on the T2 images, and there's no history of neurofibromatosis type 1. We did an octreotide as well, and this helps to really exclude that it's any kind of paraganglioma, including a rare sympathetic paraganglioma. So what was this? This was a sympathetic chain schwannoma. This is a rare tumor of the carotid space. It may present with headache or Horner syndrome. Surgery is curative, but there is a risk of postoperative Horner syndrome, and it may be associated with NF2. Thank you very much.
Great. Thank you very much for the presentation, a very nice presentation of a classic case. How was this patient treated eventually? Managed,
sure. Can you hear me? She did have it resected, and she was did not have any serious complications. There was certainly no postoperative Horner syndrome, and she did very well.
And why did they take it out? Just because was the patient symptomatic again before they take it out? Because I know one option is just to follow
the symptoms were mainly the bulge in the back of her throat, I think, was uncomfortable, and I guess also the idea that it could get larger. She was pretty young, and they figured rather than waiting until she got into trouble with it pressing somewhere where they couldn't deal with it as easily. Yeah. I think that was part of the argument as well.
Yeah, no, it's a great case. It's always the debate is always interesting in the sense: do you take something like that and take it out in a patient that's asymptomatic, because while it's, if you will, take outable, or do you let it potentially grow and then by that time it's too late to take out with a higher incidence of complications? So thanks very much for that, Dan. It was outstanding.
Thank you.
And the last paper, and this is going to be presented by Kaylin Riley from Utah. I don't know if Kaylin is here or not. I think there may be some internet or travel trouble, so hopefully she'll be here. But if not, I know this is going to be a superb case because I know the answer. Go ahead.
Hello, everyone. My name is Kaylin Riley, and I'm a neuroradiology fellow at the University of Utah. Today I'm going to be very briefly sharing a case we had of a paraganglioma that showed an unusual pattern of spread. Our patient was a 76-year-old woman who came in with a chief complaint of headaches and dizziness, and also reported some ringing and buzzing within the left ear. Temporal bone CT was done, which showed a mass centered at the left jugular foramen with associated permeative and destructive changes of bone, classically seen with jugular foramen paraganglioma. The corresponding MRI showed avid contrast enhancement, and we can see here there's these dark tubular structures within it correlating with vascular flow voids. There are also these areas of intrinsic T1 signal hyperintensity correlating with small foci of hemorrhage, and together these two constitute the so-called salt and pepper appearance, which is a fairly common finding with these tumors. What's interesting about this lesion is we can see it extending inferiorly below the skull base along the neck, and it appears to actually invade into the internal jugular vein. So this was further evaluated with ultrasound, and we can see a hypoechoic mass within the vein itself, near completely occluding it, and there's these dark tubular structures within it correlating with those vessels seen on the MRI. So in short, paraganglioma will classically show permeative destructive changes of bone on CT, as we saw in our case, and a very classic imaging appearance on MR is the salt and pepper appearance correlating with areas of hemorrhage and hypervascular flow voids, as well as avid contrast enhancement. What's unusual about this case is you don't expect to see the direct intravascular spread of the tumor, and this was corroborated on ultrasound showing that tumor thrombus. So an unusual pattern of spread for this lesion. I thank you very much for your attention.
Great. Thank you very much. I don't know if, Kaylin, let me give you I think I got an email this morning that he's post-call and maybe traveling. So let me do a sound check to see if he's here. Kaylin, are you there somewhere? Okay. If not, why don't we just go on to the next session. Thank you very much for everyone in that session. Just by looking at the comments from the chat box, I keep saying great cases, amazing, so on and so forth. So I want to thank all the presenters for their time and everyone for attending the session. And I'll now hand it over to my colleague, Dr. Rebecca Cornelius.
Good morning from Cincinnati, everyone. We're going to continue on with the last 5 cases in this session. Next presenter will be Dr. Paolo Puak from Ottawa.
Thank you to the committee for the invitation to present this interesting case. This is a case of a 41-year-old male patient who was found to have a mass in the right thoracic inlet during evaluation for immigration purposes. The patient was completely asymptomatic. Upon further review, he complained of mild pain and weakness after performing physical work with the right arm. However, on physical examination, there was no abnormal weakness or abnormal sensation in this arm. These are the imaging findings. The CT of the chest revealed a right apical intrathoracic and well-defined mass extrinsic to the pulmonary parenchyma. You can see that the lesion is extended superiorly above the first rib without any bony destructive changes. The density of the mass was of fluid attenuation. Given the location of the lesion, an MRI of the brachial plexus was performed. On sagittal plane, which is the image to your left, shows again the apical mass that extends superiorly into the scalene triangle through the thoracic inlet. The lesion also shows float voids in its intrathoracic component. On STIR, which is the image to your right, shows that the mass demonstrates signal suppression. There was mild enhancement on post-contrast imaging predominantly in the inferior intrathoracic component of the mass. The image to your left is a zoom-in sagittal T1, which shows that the lesion was separated from the C5, C6, and C7 nerve roots of the brachial plexus superiorly. However, inferiorly, the C8 and T1 nerve roots of the brachial plexus were not identified and likely involved by the mass. There was no involvement of the neuroforamina. So our differential diagnosis included a low-grade sarcoma, neurogenic tumor, a benign peripheral nerve sheath tumor, or lymphoma. The patient underwent a percutaneous biopsy of the lesion and it was consistent with a hypernoma. So hypernomas are rare benign tumors of brown fat origin. The term hibernoma derived from the resemblance of the brown fat to that seen in hibernating animals. These tumors mainly occur in adults with a female predominance. These are slowly growing, painless soft tissue masses which can be seen in different regions of the body. The key diagnosis features include a well-defined encapsulated mass with signal intensity that ranges between subcutaneous fat and muscle. The degree of suppression on fat suppression sequences depends on the nature and amount of lipids, and also the degree of vascularization will determine the degree of enhancement from absent to marked enhancement. The differential diagnosis include sarcoma, lymphoma, or tumors of fat content such as liposarcoma or lipoma. The treatment consists of surgical resection and it has been reported to have an excellent postoperative prognosis with no evidence of recurrence. Thank you so much.
Well, thank you for that presentation, Paolo. That's a really interesting case. Are you on the line here this morning?
Hello, yes, I'm here.
Hi, thank you. I'd be interested to see from the chats how many people have seen one of these. I've certainly never made this diagnosis, or if I saw one, I missed the diagnosis. Have you seen one of these before, or is this the first case you've seen?
Yeah, this is the first case that I've seen, and it was really interesting. Nobody expected this diagnosis, and I think it's important to include it in our differential whenever we see a lesion that doesn't match features of truly benign or malignant. That's kind of the middle, and I think it's a good consideration to have it from now on.
Right, yeah, and I understand pathologically, the pathologists are pretty good at differentiating the lipomatous lesions. However, I guess there's sometimes some difficulty in differentiating from the myxoid liposarcomas, but in those cases, they can do cytogenetics, and I think the hibernomas tend to have 11q13 translocations.
Right.
But
yes.
Thank you again. Very interesting and unusual case.
Thank you.
And I think we can move on to our next case. The next presentation is from Dr. Octavio Aravello from MD Anderson.
Hello everybody, my name is Octavio Arevalo. I am the Oncological Neuroradiology Fellow at MD Anderson, and it is a pleasure for me to share this interesting case with you all. This is a 37-year-old male patient with no prior oncologic history, presenting with a rapidly growing left-sided palatal mass associated with malaise and facial pain. This is the baseline CT of the neck with contrast, and here we can see this fairly homogeneous mass centered at the posterior aspect of the alveolar ridge of the left maxilla, which demonstrates a fairly homogeneous enhancement and is associated with extensive bone destruction of the posterior left maxilla. As you can see in the coronal images, here we can see that the mass extends, breaks the cortex and extends into the alveolar recess of the adjacent maxillary sinus. On the FDG PET CT, we can see that the lesion is extremely FDG avid. No other hypermetabolic lesions were identified elsewhere. This picture shows the greenish appearance of the mass at the visual inspection, and a biopsy confirmed this lesion to be a myeloid sarcoma. This is a follow-up examination after a few weeks of treatment, and we can see that there is marked improvement and regression of the enhancing mass and improvement of the mass effect upon the adjacent oral structures. The extramedullary leukemia can manifest in a wide variety of locations in the body, and it has been described almost everywhere. There are multiple forms, including the granulocytic or myeloid sarcoma, such as in this case the leukemia cutis and the meningeal leukemia. In the pediatric age, it can happen, or it happens in up to 13% of the patients with systemic AML at the time of presentation, and also can occur in patients with normal bone marrow and no history or other evidence of AML. When it happens, it is called the primary extramedullary leukemia. And this primary EML is fairly rare, it's not that common. It happens usually in children younger than 16 years, but it can also happen in young adults, as in our case. And the orbit is the most common site of involvement when it happens. It is associated with the translocation A21, and the extramedullary leukemia without acute myeloid leukemia can be often misdiagnosed as lymphoma. We have to be careful with this entity in this scenario. And most institutions usually treat these patients with anti-leukemic therapy, and the patient is deemed to have AML, even though the patient does not have any bone marrow involvement. Thank you very much.
Thank you, Octavio. That's a very interesting case. Are you on the line here this morning?
Yes, good morning. Thank you very much.
You're welcome. And again, so this patient, this was his initial presentation, correct?
Yes, doctor. This was his initial presentation. He was otherwise healthy. He was a 36-year-old, 37-year-old. Okay. It was the single lesion the patient had.
Right. And I think this lesion has gone by different names over time. At one time, we used to call these lesions chloromas. But it is an interesting dilemma that if you're not suspecting this prior to surgery, that there is a high incidence of misdiagnosis of this lesion as a lymphoma. And I did also read that, in fact, these patients who present with the primary extramedullary leukemia, it's often a sort of a precursor or heralding that they may be about to go into a blast crisis, and that indeed they are AML diagnosis patients. Thank you again.
Exactly. Yeah, that's why here at MD Anderson they treat them as if they had the full like a leukemic presentation. Even though they are kind of localized, they are treated as an leukemic state.
Correct. Okay, great. Thank you. We'll move on to our next presentation from Carrie Norris at Utah.
Hi, my name is Carrie Norris with University of Utah. This is a What the Heck Is This case for the Earlybird session. No disclosures. This is a 55-year-old man with a 2-week history of right facial weakness, ear fullness, and tinnitus. So we can see axial CT images through the right IAC. There is a permeative and destructive lesion kind of centered about the jugular foramen. Coronal imaging redemonstrates this and also shows us some soft tissue, which is extending superiorly and laterally into the right EAC. We got some MR images for further workup. So you can see some bubbly T2 brightness, some intrinsic T1 hyperintensities on this pre-contrast image, and then some pretty avid but heterogeneous contrast enhancement on the post-contrast image. So taken together, these findings can help us refine our typical differential diagnosis for a jugular foramen mass, and it definitely had some imaging characteristics most consistent with the paraganglioma. However, this spread into the external auditory canal is not typical for paraganglioma. So that mediated a workup of a biopsy, which showed some malignant cells with clear cytoplasm and prominent nucleoli. For the pathologists out there, that sounds like a renal cell carcinoma. This patient did have a CT abdomen pelvis that showed this RCC. So paraganglioma, like we said, has imaging characteristics which look like our case. It can cause permeative and destructive bone changes. There are foci of intrinsic T1 hyperintensity secondary to slow flow or phlebolysis, and T2 imaging will show flow voids due to high vascularity. However, soft tissue will invade the middle ear hypotympanum medial to the tympanic annulus and will typically not invade the external auditory canal. A metastasis, though, can do whatever it wants. So renal cell carcinomas will cause osseous destruction. They like to bleed, so you'll get these foci of intrinsic T1 hyperintensity. And they will typically be infiltrative and spread in any direction they want to. So teaching points, pay attention to the vector of spread. Paraganglioma should always invade the middle ear, not the EAC. Use all of your imaging information to refine your differential and take into consideration the entire clinical history. Thank you.
All right, thank you, Carrie, for that presentation. Are you on the line this morning?
Yes, ma'am.
Okay. Yeah, that's an interesting case, and I think it's a good reminder to think about metastatic renal cell carcinoma when you have a hypervascular lesion. It's interesting that, it does have characteristics that look like a paraganglioma. I remember a case of a soft tissue mass that I think I was a fellow or 1 year out of fellowship, and we had a patient with a very vascular circumscribed soft tissue mass in the neck in level 3. We actually did an angiogram on it. It was very hypervascular. We thought it was a paraganglioma. We embolized it. It was resected, and it turned out to be metastatic renal cell. So always a good reminder to keep that in your differential when you have a vascular lesion. Great presentation. Thank you. We'll move on to our next presentation by Mina Madian from Stony Brook.
Hello and good morning, everyone. My name is Mina Madian, and I'm an oral and maxillofacial radiologist at Stony Brook University School of Dental Medicine. I'd like to thank ASHNR for the opportunity of presenting this case today. So our patient was a 17-year-old female who presented to our dental care center with some dull pain and facial asymmetry in the left posterior maxilla, and some swelling of the buccal gingiva. Her past medical history was non-contributory. We take a panoramic radiograph, and on the pan we see this expansile entity of mixed density, which appears to be extending and expanding the sinus floor superiorly. It is also involving the roots of the first, second, and the third molar, and possibly the premolars. And there might be some root resorption of these teeth. It's also displacing these third molar superior and posteriorly. So our initial impression when we see something like this is usually fibrous dysplasia. It's very common in the posterior maxilla. It has this sort of mixed density appearance, and it's also common in this age group. However, the patient has pain, and fibrous dysplasia does not explain the pain. So we go ahead and take some advanced imaging. On our axial bone window CT, we can appreciate this mixed attenuation entity, which seems to be displacing the walls of the sinus medially, anteriorly, and superiorly, and it's also causing some erosion of the buccal plate. As you can see here, our lesion seems to be growing and expanding into the adjacent soft tissue. So we can also appreciate on the coronal cross sections that the sinus floor is elevated. However, it's maintained, but our lesion is growing and extending beyond the buccal cortical plate. And on our sagittals, we can appreciate the region of mixed attenuation entity, which is confluent with the lamina dura of the first, second, and third molar. The pedial spaces are maintained. However, there does seem to be some degree of external root resorption. So with these imaging features, we would consider fibrous dysplasia still at the top of our differential. However, because of the patient's pain and the progressive swelling, we would also consider benign osteogenic neoplastic entities such as cemental ossifying fibroma and osteoblastoma, which are not as common as fibrous dysplasia. And because of the appearance on the buccal side of the lesion and the erosion and the growth into the adjacent soft tissue, we could also consider osteosarcoma, although remotely, in our differential. So the lesion was surgically excised and submitted for histopath evaluation. And here we can see stroma of osteoid material and woven bone with areas of well-differentiated osteoblasts, which was consistent with an osteoblastoma. Thank you, and I'm happy to address any questions.
Thank you, Mina, for that presentation. Very nice case. And I liked seeing the scrolling stacks there. It made it easier for people to appreciate the whole lesion. Yeah, these bone lesions, fibroosseous lesions are pretty interesting, but I do understand that pathologically, a lot of the fibroosseous lesions can have overlap for the pathologist, so they often are somewhat dependent on correlating with our radiographic findings to come to their final diagnosis. But my understanding is that the osteoblastomas have a very typical pathologic appearance. Is that your understanding as well?
Yes, I have to say that usually that is really the dilemma. When you see a fibroosseous lesion under the microscope, they all look more or less the same along the same spectrum. But yeah, I think here really the differentiating factor was the deposition of the woven bone and also the presence of well-differentiated osteoblasts. But I totally agree with you. A lot of these times you have to corroborate your pathologic findings with your clinical and radiographic presentations.
Okay, thank you. Beautiful case.
Thank you.
All right, and we will move on to the last case of this session. This case is presented by Dr. Sinead Culleton. And I am not sure, she was unsure if she'd be able to make the call this morning, so we'll see if she's here after the presentation.
Good morning, and thank you to the ASHNR committee and Professor Richard Wiggins for the opportunity to share this case with you today. An 83-year-old man presents with bilateral neck fullness, and on examination, he had palpable discrete nodules on both sides of his surgical stoma. He had a history of a grade 2 right arytenoid chondrosarcoma, for which he had undergone a total laryngectomy, which was performed in 2008. His past medical history included type 2 diabetes, hypertension, and metastatic hormone-sensitive prostate cancer. These are selected axial images from CT soft tissue neck studies of this patient. 2008 shows preoperative imaging at the time of diagnosis, and 2012 postoperative, and 2019 this presentation. So what is going on? An axial CT image from 2008 shows a heterogeneous calcified mass arising from and replacing the right arytenoid cartilage, which was subsequently proven as chondrosarcoma, and the patient underwent surgery. This is a selected axial image from one of the patient's postoperative studies, and this shows the expected postoperative changes from a total laryngectomy and no evidence of disease recurrence, as was the case on all of the patient's follow-up imaging right the way to 2019. On this presentation, this is a selected image from the patient's CT soft tissue neck study. It shows unusual appearance of bilateral cystic masses, and these were what were palpable on the examination. Initially, this was interpreted on imaging as arising from the sternocleidomastoid muscles themselves and interpreted as a myositis and infection. But in fact, this is demonstrating new regional lymphadenopathy. These were cystic regional lymph nodes and not, as originally misinterpreted, occurring from the sternocleidomastoid muscles. This is pathological proven chondrosarcoma recurrence in regional nodes. Chondrosarcomas of the larynx are rare head and neck tumors, and even rarer is the occurrence of metastatic lymphadenopathy. Distal metastases can occur, but these particularly occur to the lungs and are in higher grade tumors. But lymph node metastases are rare. They've been reported in some case reports in the literature, for example, a case of hyoid carcinoma. Chondrosarcomas commonly arise from the hyaline cartilage, and in one series, it was the posterior lamina of the cricoid cartilage was the most uncommon origin. Less commonly involved are the thyroid cartilage and even less so the arytenoids. Chondrosarcomas can occur from multiple sites in the head and neck, or the site of origin cannot be defined in some cases. This case highlights an unusual and an unexpected recurrence of nodal disease, which was found to be chondrosarcoma recurrence. Thank you for your attention, and thank you for listening today.
Thank you, Sinead. Are you on the call?
Yep, I am. Hi, Dr. Cornelius.
Oh, great. Glad you could make it. Yeah, that's really, really interesting. I have to say I have never seen nodal metastases from laryngeal chondrosarcoma. I mean, these are rare lesions, although if you've been in practice for a long time, you've probably seen several laryngeal chondrosarcomas. One comment I was just going to make about the treatment, I noticed this patient, I guess, went directly to total laryngectomy. At our institution, the several cases that I've seen over the years, they've usually started with just serial debulking of these lesions to try for voice preservation as long as possible, since the vast majority of these are very low-grade differentiated lesions and tend to be very slow-growing. Most patients are interested in voice preservation for as long as possible, but you can reach the point where you've resected enough that the larynx becomes incompetent, and then they usually proceed to total laryngectomy at that point. Did this patient have the initial surgery of total laryngectomy?
Yeah, they had an initial total laryngectomy.
Okay. Yeah, they're rarely there. I know Dr. Curtin had a case report of an aggressive dedifferentiated chondrosarcoma of the larynx some years ago, but most of the ones I've encountered have all been of the low-grade type. All right. Well, thank you, everyone, for these tremendous cases. I think it was a great session. And I'm so happy to see everyone again. And I want to thank Alona and congratulate her on putting together our first virtual ASHNR. Looking forward to seeing everyone throughout the week.